Thank you all for your patience. This event's being recorded, so we're gonna post it online later and hopefully fix the live stream at some point. But wanted to thank you all for coming here today to attend the shadow hearing entitled Pharmacy Benefit Managers, the Drug Middlemen Who Increase Drug Prices, Limit Choice, and Hurt Local Pharmacists. This event is hosted by the House Judiciary Antitrust Subcommittee Democrats. And we're here today to talk about all the issues that pharmacy benefit managers pose for consumers, for physicians, for employers, and also for local pharmacists. We're pleased to be joined here by several fabulous panelists that Mr. Nadler will introduce here in a minute. But wanted to thank you all for attending here today and thank all of you also who are watching on the recording. Really appreciate it. I'm pleased to introduce Mr. Jerry Nadler, who is the ranking member for the House Judiciary Subcommittee on the Administrative State Regulatory Reform and Antitrust. Thank you so much.
Thank you all for coming here today to hear from members and our panelists on the need to pass pharmacy benefit manager reform and lower the costs of critical medicines. The price of prescription drugs is out of control, and it is directly affecting the health and safety of Americans. Over 9 million adults have skipped medications prescribed to them because they could not afford them, with women, people with disabilities, and the uninsured most affected. Prices are skyrocketing, and people are dying or not getting the care they need, while healthcare giants reap massive profits, merge with other companies to entrench their dominance, and obscure critical information from Congress and regulators about their practices. One reason that prescription drugs have become unaffordable for so many people is the growing dominance in the healthcare market of pharmacy benefit managers, or PBMs, who serve as middlemen between drug manufacturers, health insurers, healthcare providers, and pharmacies. As a recent FTC report found, the PBM market is highly concentrated, with the largest PBMs vertically integrated with the nation's largest health insurers and specialty and retail pharmacies, meaning the same company controls each stage of the supply chain. As a result, the leading PBMs exercise significant market power over consumers' access to drugs and the prices paid for those medicines. This includes steering contracts to their own affiliated businesses and away from local independently owned pharmacies. To address these concerns, we must act to increase competition in the PBM market. To be clear, the problem is bigger than just pharmacy benefit managers. It is true that only 3 PBMs control 80% of the market, but PBMs play just one part in our overly concentrated healthcare system. If we truly want to address the rising cost of prescription drugs and healthcare, we must also address consolidation industry-wide. But we're beginning today with a close look at PBMs because of their direct impact on drug prices. An environment in which a handful of companies control Americans' access to and prices for critical medications means that we all lose. We lose out on a more innovative healthcare market. We lose money paying exorbitant prices for drugs. We lose time fighting with our insurance provider for access to the drug our doctor prescribed. We lose knowledgeable counseling from our local independent pharmacist. And in the worst cases, we lose a loved one who could not access or afford the medicines they need. Although interest in PBMs has ramped up this Congress, their market dominance and their role in driving up drug prices is not news. When I was chair of the Judiciary Committee under a Democratic majority, the committee addressed the issue 6 years ago. But under Republican control, Congress has not acted to reform our pharmaceutical market, and the Trump administration has tried to fire key heads of the FTC, the only agency that conducted an in-depth study of the PBM market and brought charges against PBMs for inflating drug prices. Even before the Republicans took control of the Senate and the White House, Elon Musk convinced Republicans to kill a bipartisan PBM reform measure in December that would have improved the market for all Americans. I urge you all and our panelists to keep fighting for reforms to our pharmaceutical market that result in more competition, more choice, more independent pharmacies, and better health outcomes. I thank the panelists for being here today to share their stories with you, and I am now pleased to introduce them. Brandi Chane is with Pharmacists United for Truth and Transparency and owns a community pharmacy in Texas, as well as serving as a state and federal advocate for community pharmacies nationwide. Bil Schmidtknect is here from Wisconsin to share with you how a non-medical switch of a medication with no notice can result in the loss of a loved one. He is now a vocal advocate for patients' rights. We were also joined by Ashley Bacot, a health plan architect for the Rosen Hotels and Resorts in Florida, who can share what employers see when they choose a PBM provider and how employers can leverage their role to ensure better health outcomes for their employees. Dr. Jim O'Leary, who also joins us from Florida, is a tireless patient advocate who wants to restore affordable and personalized health care for all and can share the doctor's perspective on PBM's control of the drug market. And finally, we are joined by Matt Seiler, who serves as counsel for the National Community Pharmacists Association and can detail how the concentrated PBM market that is far too often vertically integrated affects local pharmacists' business success and how they can counsel their community members. Now I would ask each of the witnesses to give a brief opening statement before we turn to questions. Let's start with you, Ms. Chane.
Thank you so much for the opportunity to be here. My name is Brandi Chane. I own Davis City Pharmacy in Weatherford, Texas. I can tell you that when I bought my pharmacy in 2020, I was beyond excited for the opportunity. We opened in 1892. I grew up in that pharmacy. I know every inch of it. What I quickly learned is that the success of my small business had nothing to do with how well we did our jobs, and it was completely reliant upon decisions made by billion-dollar corporations with contracts that we weren't able to negotiate, patients that we often had to turn away, or patients that were forced to seek care elsewhere. While I appreciate all the work that's been done over the past couple of years, including hearings and investigations, wonderful legislation that's been introduced, it seems like we continue to stall at the very last minute. So my ask as a small pharmacy business owner is that in this new Congress, we see action. We know that this is a bicameral, bipartisan issue, and the time for action is now. And so I appreciate the opportunity to be here today.
Mr. Bacot?
Hi, thank you for having me here today. I'm with Rosen Hotels and Resorts, and 33 years ago, we thought we were going to have a good renewal. Our claims cost was significantly lower than the premiums we were paying. And when Mr. Rosen met with the agent, he said, your premiums are going up. And Mr. Rosen said, oh, no, they can't be because our claims are so much lower. And he said, well, you're in a pool, and the pool didn't do too well. And he goes, oh, I didn't know I was in a pool. I don't want to be in a pool. I'm not that kind of guy. Well, you have to be in the pool. And so we just figured at that point healthcare was not sustainable. So we became self-insured. We hired a third-party administrator. We did direct contracts with hospitals and specialists. We opened our own on-site clinic, and we have a transparent PBM. Our costs are about half of what our identical demographic would experience in the traditional, healthcare setting with the big insurance companies. And typically when you lower the cost, there's a commensurate reduction in benefits, but quite the contrary. So we have no deductibles. We don't have any co-insurance. 90% of our drugs are no copay. It doesn't sound real, I get it. It does not sound like that's true, but it is. Our chronic conditions, hypertension, diabetes, and cholesterol have compliance rates that are about twice the national average.
Excuse me, would you turn your mic on, please? And everyone, as you speak,
are about compliance rates with hypertension, diabetes, and cholesterol about twice the national average. And it didn't come from any sort of rocket science decision that we made. We simply, instead of spending 3 minutes with a patient, our doctors spend 30 minutes with the patients, build a relationship, and are more likely to do what the docs say. Listen, we've still got people who are chasing around around trying to work with, but it works when you build a relationship and spend time with him. We've saved about $540 million over the 33 years, and we've invested a lot of that in underserved communities. And so we adopt communities, we pay for their 2-, 3-, and 4-year-olds daycare, and in exchange for allowing us to read to them. And so they start school reading better than the folks in this room's kids read, underserved communities. And then we tutor them all the way through high school, and when they graduate high school, we pay for college education, books, tuition, room and board, coming home for holidays, that sort of thing. And graduation rates have gone from 50%, 50, to 100% in high school, and then crime has gone from it was really rough neighborhoods and into virtually non-existent crime. And so, fixing healthcare can allow you to have some extra money left over to do some things that need fixing as well.
Dr. O'Leary.
Thank you very much for inviting me here today. And I graduated medical school in 1985, and the whole medical universe was entirely different. I would sit in the exam room with the patient, and this is even before we had a computer, so I didn't have to type anything, and I could look the patient in the eye. And I could sit there, I could get to know them, much as Ashley was saying. And one of the things that happened, I could decide, along with the patient, what medication to prescribe. They would go to the pharmacy, they would get it filled, no big deal. But over time, I realized that that was gone. Now, all of a sudden, the decision of what prescription could be chosen was on the shoulders of somebody else. Who was it? The insurance company, the PBM? You don't even know. So what happens is with non-medical switching, which Bill's going to talk about, non-medical switching is when the PBM decides to change the medication that I put a patient on. Now, when I write a prescription, I'm taking a lot of responsibility. It's in the medical record. It's permanent. All of a sudden, somebody on a formulary, a committee, has now changed it. They've never seen my patient. They never examined them. They don't know anything about them. And these committees are made up of pharmacists and physicians, but there's no physician's name on it. There's no accountability. This is the corporate practice of medicine. The corporate practice of medicine is a terrible idea, should be outlawed. Even if the prescription that I want to put a patient on is on the formulary, the patient may go to the pharmacy counter. I don't know what their cost is going to be at the pharmacy counter. It could have changed. The formulators change frequently, even though they say they don't, they do. The cost sharing, which is a terrible thing, affects the patient. So I don't know if they're going to be able to afford it. And you know what happens a lot of times when people can't afford their medications? They're ashamed. They don't tell their doctor. We don't even know. We can't even help them. So we wonder, why are they getting worse instead of better? We don't know. So I'm here because I look at the PBMs as part of the vertical integrated system that Congressman Nadler correctly pointed out as a problem. And I have no skin in the game financially. I don't own a pharmacy. I'm not going to make more money if PBM reform gets passed. But I have skin in the game because I have grandchildren. I want them to have access to a great health care system. And that's what I dedicated my life to. So we all know this is bipartisan. And I agree that there were some crazy games at the end of the year, but, and that's bad. But I don't come as a Republican or a Democrat or a conservative or a liberal. To me, this just needs to be done. How do you say that we should prioritize middlemen that are taking hundreds of billions of dollars from a system, and then with that money that they take, they underpay pharmacies, drive them out of business, and they inflate the cost of medication. So right now, we pay about $720 billion for all our prescription drugs. We pay 2.8 times what other countries pay. If we paid just the average, that would be $260 billion. We're being overcharged $460 billion a year. How are PBMs saving us money? There's absolutely no way they're doing that. That is crazy, we're overpaying. Now, we have the biggest prescription drug market in the world. If you look at Walmart, they have the cheapest prices for sodas. You know why? Because they have the biggest market. They demand the best prices. We should be demanding the best prices, not the worst. To me, the negotiation is easy. We pay great prices for generics, so it's only branded medications. You're probably talking about $2,000 prescriptions, medications you'd have to negotiate for. And I think Bill and I could do this negotiation within a month. I don't think this is hard. So please, let's get this fixed. I implore everybody, Democrat, Republican, please fix this. Thank you so much.
Thank you. And so the legislation will abolish PBMs and appoint the two of you as a national committee.
That works.
Mr. Schmidtknect.
Good afternoon. My name is Bil Schmidtknect. Yes, I'm a patient advocate after losing my 22-year-old son. And it was a very crazy situation that we're still trying to wrap our life around right now. But he walked into a pharmacy and couldn't afford his medication. Not only could he not afford it, it was skyrocketed from the year prior. $60, over $500. And there were other factors that evening too, where that was his only option. And he left that pharmacy without anything and suffered an asthma attack 5 days later and passed 6 days after that. That put a charge in me like you wouldn't believe. Plain and simple. That's why I'm here today. That's why I've been coming to Washington these last few weeks. That's why I quit my job. I quit it. And now here I am. This is what I do. And everything that these panelists have talked about prior to getting to me is everything I found out. I did not know what a PBM was on January, we'll say 20th or 20 of 2024. No idea. But I unfortunately abruptly learned. And the games that are played, and I'll call them games, I don't know if you want to say that or not, but the deceptive tactics, the non-transparency that occurs, the greed that happens, and then just the true putting profit over patient safety has to stop. Not to mention how the pharmacies are closing out there, because that's just as bad, because now we don't have doctors or medical professionals in the community as it happens more and more. So long and short of it, we've been, as I've gotten involved with this, and I've seen a lot of activity with the PBM reform that's happened, and yes, there were some shenanigans that happened last year, whatever you want to call it. I don't think we're defeated, but we're not where we need to be. The best part is that we're here today. We're having this committee. We're going to learn more. My son's life, well, let's just say this. Cole's not here. I can't get anything for him other than justice. Truly, I need to live and say that, or my wife and I live and say, no one else needs to get hurt or die from this, and we're going to make sure that happens the best we can. So,
Mr. Seiler.
Thank you. In 2023, the United States spent over $722 billion on prescription drugs.
Put on your mic, please. It's on. Okay.
Is it on? Okay. Today, many Americans are financially strained and unable to afford the soaring cost of life-saving medications. This affordability crisis is in part the result of the most powerful health insurance conglomerates' takeover of the healthcare stack and the platformization of healthcare. The conglomerates I speak of are CVS Health with the Fortune Global rank of 10, United Health Group with the Fortune Global rank of 8, Cigna with the Fortune Global rank of 33. They have leveraged their market dominance to stifle competition from independent pharmacies, harming American consumers through exorbitant prescription drug prices and reducing healthcare access. Good afternoon, my name is Matt Seiler, and I'm the General Counsel of the National Community Pharmacists Association. Thank you for providing me the opportunity to provide testimony on issues that are well known to independent pharmacies and the American consumer across the United States.
Thank you for your testimony. I'll now begin questioning the witnesses. Mr. Seiler, can you share with us how independent pharmacists are affected by the highly concentrated and vertically integrated PBM market?
Sure. Independent pharmacies are at the mercy of vertically integrated PBMs. They're concentrated marketplaces and what we believe are the anti-competitive activities by these entities. In many metropolitan statistical areas within the United States, one or two PBMs control significant aspects of the marketplace. In Buffalo, New York, for example, a survey by the American Medical Association demonstrated that Cigna's Express Scripts had an 86% commercial market share of the management of the pharmacy network. Market shares like that make it impossible for independent pharmacies to not be in the market. Who can give up 86% of their commercial customers and stay in business? These concentrations result in outsized leverage, and it gives the PBMs the ability to steer patients to their own pharmacies, force unconscionable contract terms, conduct unfair and punitive audits, charge excessive fees, under-reimburse competitors, use coercive market tactics, and exploit undisclosed conflicts of interest.
Ms. Chane, you own a pharmacy in Texas. How have PBMs affected your business and the ability of our pharmacists to effectively counsel their patients?
Thank you for the question. So we're often presented with contracts that when we look at them, it appears like this is unreal. I can't believe this is what's being, presented to us. It's things like if I sign this contract and I dispense this medication, I will for sure lose money on this transaction. Or things like I'll get 85 cents back on this claim. So I might not lose money on that claim in terms of what it cost me to purchase the drug, but the average cost to dispense a medication across the United States is around $12. So even if I am reimbursed at least what it cost me to purchase this medication, I'm losing $12 on every one of those claims. So I ran my book of business for 2024, and I looked at how many claims it took my pharmacy to get to before we cleared a minimum of $12, just gross profit. So in order to get to $12, I was at 15,314 prescriptions before we ever cleared $12. The first 5,000 of those claims was below the actual acquisition cost of the medication. So those 5,000 claims, I was paid less than what it cost me to purchase the medication. So then, what do? Okay, you start to figure out, okay, what can I do to supplement this? How are we gonna survive this? So then what happens is you have to start letting staff go. Because, you gotta figure out how to keep the doors open. So when I bought my pharmacy in 2020, we have since had to let go of 70% of our staff, which then what happens is patients, we don't have time to spend the time with patients that we really should. Are we talking to them about diet? Are we talking to them about exercise? We don't have time to do that. We're just trying to answer the phones and get deliveries out as quickly as we can and make sure that drug interactions are being checked. So every time that, as I said, these billion-dollar companies start squeezing us more and more and more, not only does it affect our bottom line, but it affects the community that depends on us to take care of them.
Thank you, Mr. Schmidtknect. Your family suffered a heartbreaking loss because of a PBM's decision to prioritize profits over patients. What would you want every member of Congress to understand about the real-life consequences of these corporate practices?
Well, I guess the first thing we got to say is let's look at what we're dealing with. It's not even broken. It's working as designed, and that's the most shocking thing that I've learned. It's unbelievable that that pharmacy owner right there just talked about the contract. Here's a contract. It's net profit. You might lose some. It's all right, and it turns out to be devastating effects. Not only, like my son in the absorbent price, there was no checks and balances. It's just insane. But what changes do I want to see? I want to see pharmacists reimbursed as a medical provider. I want to see every patient that visits their doctor and needs to get a prescription to walk out with medication, just plain and simple. There should be no games of step processes and all the prior auths and the extra prior auths. Obviously, there's some rational stuff that has to happen, but let's get back to rational. And I pay my premiums. My son paid his premiums. He worked full-time and he walked out with nothing. Think about that. And that's what's crazy about this whole thing. And it's not broken. It's working as designed. So we got to change the design and get it to work for us.
Thank you, Dr. O'Leary. PBMs, as you mentioned, often steer patients away from drugs their doctor has prescribed and to another medicine. How would you fix this?
A couple different ways. First of all, I don't think PBM should be involved in constructing formularies or price negotiations because there's huge conflicts of interest. The other big conflict of interest is that the insurance company is really the client of the PBM. Yet now the insurance companies own the PBM. That makes no sense. So we need to have separation. So insurance companies should not own PBMs flat out. The other thing we need to do is undo what was done in 1987. Were you in Congress in 1987? No. Okay. So it's not your fault. So you're off the hook.
And if I were, I probably wouldn't remember everything we did in
Okay.
1987 anyway.
Well, that was when, I think this is one of the most interesting things that happened. You have a Medicare fraud and abuse law. So that sounds like a good thing to have, Medicare fraud and abuse. But in 1987, Congress said, you know what? Let's give a hall pass to that law, and it was an anti-kickback statute. Let's give a hall pass to group purchasing organizations and PBMs. Why would we do that? Who thought this was a good idea? So what happened is
What do you mean by a hall pass?
a hall pass, I mean, they got a safe harbor. They got an exemption. So the PBMs now can get kickbacks, which they call rebates. It's legal. If I took a kickback as a physician under Medicare, Medicaid, I would be in an orange jumpsuit. And I would be fined, and I would be banned from all federal health care programs for life. But they get an exemption. So what happened was before, really the person paying the PBM should be the insurance company. They should pay them a flat fee. But now they get lots of money from the manufacturer. That sets up a huge conflict of interest. And that's why the prices increase, because then they started demanding, the PBM started demanding rebates. So the manufacturer said, okay, if we give you a large rebate, then we get a good place on the formulary. And the second thing happened in 2012, CVS Caremark had the first exclusionary formulary. So they said, Eli Lilly, your medication, Humalog, is off. Now you can imagine if you're a drug manufacturer and CVS Caremark, which has 34% of the market, excludes your medication. That's huge. Why do they have this power? It is insane. So we need to get rid of the rebate, the anti-kickback statute, safe harbor. That needs to go. That's got to be gone. And that will help us out because the GPOs work for the hospitals. And we just recently had this situation with IV drug shortage. And they said it was because of the hurricane in North Carolina. And we're like, okay, so we're the United States of America. We are technologically very advanced. And we can't figure out how to put salt water in a bag. Come on, that's a joke. The reason it really happened is because of group purchasing organizations. They control what happens is you have to pay to play. So if you're Baxter and you pay lots of money, you get a sole source contract. And then you have no incentive to have a lot of manufacturing capability, and there's no competition. So we need to undo this law. And that's the law for that. But I'm glad you didn't vote for that, sir.
Mr. Bacot, how can an employer ensure that the PBM they select for their employees best serves the health of that staff?
When we were just kind of, when Mr. Rosen fired that insurance broker that day, right, and we didn't know what the heck we were going to do, we just used our common sense in the hotel industry. Hey, let's go to the big guys who have all the leverage, right? It just seems like it makes sense. You know, the CVS's that you mentioned, the big three. It didn't work too well, and so counterintuitively, we went to a very tiny little PBM out of Michigan, and we noticed our costs were really going down. Okay, and it was because it was a transparent relationship, and we just paid a very reasonable administrative fee, okay, to the PBM. We paid a reasonable dispensing fee to the pharmacy, and the rest of it was kind of pass through. So it was kind of very, very, very simple. But when you're thinking about what's the best thing to do for our employees, we want it to be affordable. And we want to control the formulary. We don't want the PBM to control the formulary. We as the employer control it. And we also, because we are saving money by not allowing that spread pricing to take place, because we as the employer are saving money. We can pass that savings to the employee. And so again, 90%, maybe it should be 100%, but 90% of all of the drugs for our employees are zero copay, which really helps, people to have access. And we also want the local independent pharmacies to be in network and to be reasonably reimbursed. So it's not. Again, I'm just speaking from the employer standpoint. I'm speaking from just that subset of the marketplace, which is the commercial marketplace, and it's. We're hoteliers. Our core business is hotel. We don't know much about healthcare, and it's kind of simple to do, and we would just wish more people would do it.
Mr. Schmidtknect, same question for you, but on the self-employer end, how do you go about selecting the best plan?
Well, just from obviously the personal experience, but as Mr. Bacot just said, they want to make sure that they can do their own formulary. Well, that's a good thing. I really do agree with that. But, right now, they are responsible for their formulary and they do nothing with it. And I think that's a huge problem. So if I was what I want out of the self-insured employees, understand your formulary. That's one of the biggest things. Understand it and don't accept the word like, well, don't worry about it, be seamless, because that statement does happen on the prescription drug benefits, and that's probably the biggest thing, other than making sure that you watch your broker over everything, because, from untimely changes of the formulary to not notifying people of formulary changes. I think that's the biggest thing that the self-insured company needs to have. So know your formulary, know that you are thinking you're in a good relationship. Make sure that relationship is really good with your broker before you just trust.
The final question is of Dr. O'Leary. You mentioned, you spoke about PBMs substituting one drug for another. I assume that the best legislation would say they can't do that. If we can't pass that kind of legislation, how helpful would it be to say that the doctor who is on the committee, whoever does this, has to have it sign his name to it and has to give the reason for the switch?
I think that's a good question. The other thing that I would put in there is that there should be no non-medical switching for somebody who's on a medication already for a chronic condition. Because what we're really talking about is they're switching it solely so they can make more money. That shouldn't be an acceptable reason. So I don't buy that. Now, if they said there's a new medication available and we think it'll be more cost effective and it will do the same thing, I think that's very reasonable, absolutely. But then put down that reason, and I think no problem with that, except that that's not what they're ever gonna do.
If they were doing that, would you want them to get the okay of the original prescribing physician who
Yes.
might know something about the patient?
Yes, sir. So what they should do is something like that is they should notify the prescribing physician as well as a patient. And I think that's a conversation you have with the prescribing physician to say, is there any other reason, or we want to do this switch, but is there something that you think would preclude this switch where it wouldn't be in the best interest of the patient? And that's the part I miss about when I started out in practice. Physicians talk to each other, and pharmacists and physicians talked. And we were talking about this earlier. When I had an inpatient patient and they had a problem with their kidney function, I would just call the hospital pharmacy. And I was like, listen, I have somebody who has a creatinine of 3, they have diminished kidney function, I need to treat this infection. What do you think would be the best medication for that? And we would talk it through, and then it's okay, thank you, and I'd prescribe that. So I think if you're going to allow them to do switching, it shouldn't be non-medical. Now, if they're going to switch things and somebody's not on it and they're going to switch within the same category, I think that's okay. So if you're going to say, like in Cole's case, if they said, okay, we're not going to cover Advair for new people, we're going to cover Symbicort, which is in the same, I think that's okay. But if somebody's on it, no. And there's literature out there saying that there's a net negative effect on patients when you do non-medical switching. And to me, the effect on the patient is the gold standard. That's really what we care about. And And I don't think there should be non-medical switching, again, for a patient who's on it already. And the other thing I saw in my practice, I'm an OBGYN, and this drove me nuts. I would work with the patient closely, and I would get them on a birth control pill that would regulate their bleeding. And it might take me 3 pills. I finally got it done. And then you get this notice. They'd say, well, the insurance is going to switch it. And I'm like, no, I'd call them up. I'd say, it's not the same medication. They're like, well, yes. I go, no, you don't understand. It's not going to work the same way. And I would fight. But the thing is, the average physician has 45 prior authorizations a week. And what they do, the insurance companies do, is they slide all these things there, so then they know they're going to wear you down. Can you have 45 conversations a week and spend half an hour? They know you can't. So that's the game that's played. But anyway, so I would not allow that, sir.
Thank you. I'm now pleased to recognize the Honorable Chuy Garcia of Illinois.
Thank you, Ranking Member Nadler, and thank you all for coming out to this shadow hearing as well. And of course, I want to thank all of the witnesses for providing the tremendous insight that this issue and this cause warrant. This conversation is real. It's much better than conversations that we hold in the full committee, where we don't have a majority at the present time. And of course, I much appreciate the urging of bipartisan action, not just talk in committee, but to finally do something about this issue. So as we've heard from the ranking member and from the witnesses, PBMs wield enormous power over the cost of prescription drug prices, and decades of mergers and acquisitions have given us 3 of the largest PBMs now that control 80% of all prescriptions filled in the U.S., and the top 6 manage over 90%. And because of vertical integration, this monopoly is enabled to continue to exist and concentrate additionally. PBMs are connected to insurers and pharmacies in a way that allows them to hide information, to jack up prices, and to profit at the expense of the people that I represent, that most members of Congress represent, and that is working families. So if PBMs have so much control over prescription drug prices, how should we evaluate their job performance? Well, the U.S. has the highest prescription drug spending per person, as has been pointed out, in the world. Drug prices here are 2 to 4 times more expensive than in other countries. Over half of adults are worried about being able to afford their families' prescription drug costs. The cost burden imposed by PBMs is especially devastating for people who are uninsured, like many in my district. People tell me that they're having to ration their medications, skip doses, or go without critical prescriptions altogether because the costs are just too high. So let me ask you, Mr. Seiler, how do PBM practices affect the uninsured, and what does this mean for those who are already among the most vulnerable when it comes to accessing medications that they need?
Sure, and thank you for the question. It relates a lot to what Dr. O'Leary was speaking about earlier as it relates to rebates. So it's actually quite simple. So PBMs are set up to manage insured patients. However, part of their process of doing so is they set up formularies, and they do formularies as a result of rebates that are being paid by drug manufacturers. But because a lot of the employers are now asking or demanding for rebates to flow through, they've actually converted those rebates now to fees. I like to jokingly call them fee-bates, but it's basically the same thing. You have either a rebate or a fee that is hyperinflating the original price of the drug. So when you're an uninsured patient and you come into a pharmacy, you're actually paying for the original price of the drug that has been hyperinflated as a result of the rebates and fees. So that is why that uninsured patient, when they come into a pharmacy, is paying a lot more than what they would if they didn't have that system in place. If the PBMs take issue with that, I would suggest that what they do is they start to advertise what the cost would be for that drug at the pharmacy counter. Other industries have been advertising their prices for services for years. The airline industry has done it for decades, and year over year, you can see that there's actually a decrease, with the exception of a few cases, in the cost of an airline ticket. That's because there's competition in the marketplace. Here, all we have is no transparency, no competition, and so therefore, an uninsured patient actually pays a hyperinflated price.
Well, thank you for that. So I think it's safe to say that the PBMs are doing a terrible job for working families, and they deserve every bit of the criticism that we've heard, and we haven't even opened it up to the public yet. So in the one, I want to underscore a couple things. While both parties criticize them, only one party has done anything. In the 117th Congress, where both the ranking member and I were members of, we passed the Inflation Reduction Act, which expanded Medicare benefits and lowered drug costs, including by capping the price of insulin at $35, which everyone here knows. And unfortunately, it should have been a bipartisan effort, but it wasn't. The House Judiciary Committee also passed 3 drug pricing bills, as has been previously underscored, which Republicans failed to advance. And just a few months ago, Elon Musk blocked, of course, the PBM reform bill that was bipartisan. So instead of doing anything to help working families, Republicans are doing everything they can to violate the Constitution and gut federal agencies on behalf of people like Elon Musk. And that's exactly why Trump is trying to fire Bedoya and Rebecca Slaughter as FTC commissioners, because they actually fight for workers and consumers, not billionaires. With them and Lina Khan in charge, the FTC was doing incredible work on PBMs, releasing multiple reports and bringing a historic lawsuit against them for artificially inflating the price of insulin. Now, the future of these efforts is uncertain. That's why I was proud to lead dozens of my colleagues alongside Ranking Member Nadler in a letter urging President Trump to reverse these illegal attempted firings, and of course urging Chair Ferguson to focus on tackling the nationwide affordability crisis. My second and last question, once again to Mr. Seiler. Why is it important to have an FTC that's committed to addressing anti-competitive practices by PBMs?
Well, I think as in any industry, it's important for us to enforce the antitrust laws that we have on the books. I don't think there is any requirement for Congress to pass any new laws. It's just that we have chosen, I think, over the last 40 years to use basically a theory to enforce our antitrust laws as opposed to actually enforcing the laws that are on the books. I believe that we have had in the last couple of years an effort to sort of change that way of thinking, if you will. I believe that way of thinking is also continuing to change in this current administration, and I'm hopeful that we will see continued enforcement and action from this FTC and the DOJ's antitrust division.
I wanted to open up the floor to some questions, but while you think about your questions, I have one for our panelists. Feel free to jump in, whoever would like to respond. We've talked a lot today about pharmacy benefit managers and how they affect patient choice, health outcomes, and how they also affect independent pharmacists. But obviously, they're one part of a bigger ecosystem. Once we reform PBMs, which there's a lot of interest in doing, are there other things that we should be considering as members of, or people who work for members of Congress to help reform drug prices and ensure better patient outcomes?
I think that we also need not only drug pricing, but there's so much consolidation in healthcare that it's a huge problem. And it affects two areas. So there's hardly ever any independent hospitals. As you drive through district after district, they've all become big healthcare systems. And what happens when they become healthcare systems? They have tremendous power. They go to these nice employers and they say, we're going to charge you 35% more. And what happens is that the hospitals get lots of special payments that physicians don't. So they get facility fees. If you're seen in an independent imaging center, you could pay, in my town, $312.50 for a CT scan, abdomen, pelvis with contrast. You go to the ER, that might cost you anywhere from $3,500 to $9,000. So we're talking 10 to 30 times X. We are broke as a country. We have a $2 trillion deficit. Our debt, I don't even know. I heard 37 trillion. I don't look at that clock because it makes me ill. But a lot of it is healthcare. And the good news is we can get healthcare costs down. And the way we can do it is we need to do what people do best, let them shop. So there's nobody in the world who's going to pay $9,000 for a scan if they can pay $312. So we need to put the power back in the patients. We need to do that through expanded HSAs. We need to let them buy the policies they want. Let them do catastrophic policies if they're young, and let them shop for the other things. Let them shop for, most of the drugs are generics. Let them go to Cost Plus. I mean, you can buy 80%. Let them go to Brandi's pharmacy. 80% of the medications are generics. They're cheap. The other day, I had 2 prescriptions filled. One was for $4. One was for $2.10. Why do you need insurance for that? That's crazy. So we need to get people paying things because we all know when we shop, we do much better. And the whole third-party system is failed because it goes against human nature. The HMO days, which were in the 80s, were a complete failure because they said, one price, you get everything you wanted. So everybody's like, I'm going in all the time. It doesn't work. But if we shop, we're really good shoppers. So let's get America shopping again. Let's get the free market going back in the system. Let's save this great country from going bankrupt and take those savings and use it for other things. So that's what I would like to do. And thank you so much.
So one thing that I think is really important, especially in these federal programs, is there need to be comprehensive audits done of these programs. Oftentimes they report savings and, things like TRICARE or the Federal Employee Benefits Program, they're reporting back that savings are happening, but we're not requiring them to show proof of that. That is the first and I think the most effective thing that we can do is put your money where your mouth is and show us what's actually happening. And the other thing is when we start examining legislation and what can be the most effective. So especially in Medicare, Medicaid, there are options where you can set a floor on reimbursement for pharmacies, but you can also set a ceiling. So what happens in the specialty market is these specialty drugs are forced to PBM-owned specialty pharmacies where we see these insane markups, thousands of percent. It really makes no sense. But the PBMs have control of that. If you set a floor and a ceiling, you cut that cost down immediately. If they can no longer essentially mark these drugs up so that they are the ones that are benefiting from this, we've cut costs overnight. That would be my 2 biggest suggestions.
I think that, no spread pricing, okay? And if we can't accomplish that, at least advertise, about the folks who don't do spread pricing. I think could guide employers in the commercial setting just to go to those folks who do the right thing. I think we need to be sure the employer owns all the data and has full access to the data. I think those are key.
Thank you. Any questions from the audience? Yeah.
So we have a number of pharmacists who are watching the hearing or have been. trying to anyway. And so this is a comment that comes from one, but I would be curious about anyone's from the panel, what they might say about it. So he says that studies show when a pharmacy desert happens or a pharmacy closes, we have lower outcomes in the affected areas, but PBMs still claim their mail order service improves outcomes, which is still available in those affected areas. So in other words, the affected areas get mail order, but the outcomes are actually going down. So it's just, I think what he's asking is for your comment on what happens when, pharmacy deserts emerge. What is the actual real impact on those communities?
So just going to repeat it for our recording. So we have a question from a pharmacist who's asking about pharmacy deserts and what happens to patient outcomes when a pharmacy in your region closes and you're pushed to a mail order system, wherein the PBMs usually report that the mail order system has good patient outcomes despite what we may see on the ground. Asking for any of the panelists' comments on that.
Sure, I'll address that. So when you have a pharmacy desert and the PBMs say, oh, just rely on the mail order pharmacy and you'll be fine, you're losing contact with a provider. I love my mail carrier. He's a great guy, but he can't take my blood pressure. He cannot administer a vaccine. He cannot blister pack my medications if I need that. There are many things that pharmacies do, innovative, cutting edge things that community pharmacies do that you cannot get through mail order. It's just not a replacement, plain and simple. If you're on, say, a single medication that doesn't need much oversight, then perhaps you're one of the exception. But sometimes even those folks have issues. And that means if you have an issue, you can't talk to your pharmacy provider. You have to go in and see your physician or your nurse practitioner or whomever. And so that's an additional visit to a provider that could maybe perhaps be seeing someone else. So it's not a good substitute at all.
I would add one other part to that, and I don't want you to think that the PBMs are being magnanimous with their offer to do the mail order. On page 42 of the first FTC interim report, it describes a conversation that they found, and it was about a drug called Gleevec. And it said that the non-preferred pharmacy, Costco, the patient could get 1 month of Gleevec for $97. The preferred pharmacy, Walgreens, they could pay $9,000. And, it's getting better, sir. And for the mail order, it was $19,200. And what the person was worried about was the optics, because they said when you aggressively steer patients for the most, which is what they were doing to the mail order, the government may get upset, because when you have a preferred channel, it's supposed to be less expensive, not more. Now, if you were savvy and you went to Cost Plus, you'd pay $36.50 for the same drug. So this is why what they're talking about is they're forcing out their competition, so you do their mail order. Their mail order prices are crazy. And that's considered a specialty medication when they send it for $19,200, but when Mark Cuban sends it for $36, he doesn't consider it special. And the definition of a specialty medication is, we don't know. There is no definition. So it isn't that there's special handling to it or anything. They just send it in the mail for that $19,200. So that's the reason why they want to keep that going. They're not there to help us.
So coming off of that question, and I really appreciated, Mr. Seiler, that you noted where patients go if they do have questions, which is back to their physician. But just want to ask about the implications of that. There's a lot of supplements and other things that you're taking over the counter that may have huge interactions with drugs, like St. John's wort or even citrus fruits. So when we don't have a provider in the area that can talk to you about those drug interactions or food and drug interactions, what do we see when we, just speculatively, like how does that affect the patient's health? And are they also making these appointments? I know I'm not usually excited to make an appointment with a copay just to check in on a drug interaction when I could have done that with a pharmacist.
Yeah, I think pharmacists should be compensated for that provision of care, but aside from that, if you have somebody that has cardiac issues and they're on certain medications, some of them can't eat things like grapefruit, for example. And so they might be at home just having come back from Florida or something with a bunch of grapefruit, and they're eating the grapefruit and their medications are not working. And they don't know why. if they had a pharmacist in the community, they might be able to go in and have a conversation. And what's interesting about having community pharmacies is they often know their communities. They're often like people that have gone from grade school through university and come back to the town, so they know folks. They're the ones that were injecting, vaccines into people's arms during COVID when there was a lot of resistance to that, because there is trust there. They know these folks. And so having that trust, having the ability to be able to sit there and talk to people, and those people know and trust you, really makes a huge difference. And that's not available through the mail order. My parents are both on Medicare, and my dad has certain issues going on where he had certain medications that were prescribed to him, and his Anthem plan changed his benefit from one year to the next, buried it on page 4 of his annual change of benefits notice, and it went from a co-pay to a co-insurance. And so because of that, he couldn't afford his medication at the local community pharmacy in Alexandria, Virginia. Instead, he and I'm a nurse also in addition to a lawyer, and so he and I sat down and we were like, okay, how can you get this medication? And so he ended up getting it through Cuban's Cost Plus, which is a great disruptor in the marketplace. But again, my dad is now missing 2 opportunities to see his pharmacist, because now he's taking 2 medications through mail order. And so he has a lot of comorbidities that are there and present that I think a pharmacist, especially the one in Alexandria, would know about and help him. But that's no longer there. So it's just not a good alternative.
And a question for Dr. Leary coming off of that. Let's say you have a patient that needs a medicine urgently. If they are in a pharmacy desert or they're pushed to a mail order pharmacy, are they able to usually get their medication filled that day, or do they have a lag because of the postal system?
They definitely have a lag. And there's times where even, Cost Plus, sometimes they can't deliver it. There's issues with, storms in a certain area. I mean, so there's a lot of times you can't. So you absolutely, the mail order is not going to solve the desert problem. And you definitely need to have those folks there. So, and there's people, especially in rural areas, you hear these stories, you're 9-year-old ladies that are now 40 miles away from the closest pharmacy. I mean, that is insane. And the thing is, there is plenty of money in the system. It's not that there's not enough money to pay the pharmacist. There's hundreds of billions of dollars. The CEO of United Health Group made, $26 million this year. Isn't that awesome? Yeah, up 12% from last year. I mean, there's plenty of money, and he's not the only one. I mean, all the C-suite are making millions and millions of dollars. So there's plenty of money. Let's put it, right now, the system right now favors middlemen. And this is how it was designed. You're right. It favors middlemen, and it punishes all of those who actually touch the patient, who provide the care. It's absolutely backwards. The other things that rebates do, which kind of flips things on the side, is if you have, so it's not only Representative Garcia was saying those without insurance, but a lot of people with insurance are penalized by high list prices. If you have a high deductible, you have to pay the list price. If you have high coinsurance. So oftentimes patients are paying more money than the employer is because of a high list price, because the employer gets the rebate back. So now what ends up happening is that the oldest and sickest employees are subsidizing young and healthy. And the employers are making money off you when you get these prescriptions filled. None of this makes sense. This is why we have to change it. So I would do is take the PBMs back to their roots and just have them be claims processors. They should not do anything more than that, because we've tried it. It has failed. They have failed, and they need to be separate and out of these conglomerates. And the other thing is that insurance companies should not own physicians. The largest employer of physicians in the United States is Optum Health, which is part of United Health. They employ 90,000 physicians. And there's a lot of articles in the Wall Street Journal talking about the pressure they were under Medicare Advantage patients to give them diagnoses that aren't clinically relevant to get more money from the program. And everybody knows about this. And, and the thing that made me really upset, made my blood boil, is that the head of CMS, I won't say Dr. Oz's name, gave a 5+% increase to Medicare Advantage plans. Okay, so the Medicare Advantage right now, last year, was overpaid compared to traditional Medicare by $83 billion under MedPAC. Okay, they're already getting overpaid, and it's for two reasons: patient selection and upcoding. Everybody knows they're upcoding. So they're getting paid for chronic illnesses, yet there's nowhere in the medical record that these chronic illnesses are being treated. And they're sending home health nurses out to the patients' homes to make these. So we all know that these aren't real diagnoses. So this is the problem, but they got 5% increase for that. I mean, that is, as a physician, it was very disheartening. And physicians last year got a 2.5% decrease from their Medicare fee schedule. So all those who are touching patients are getting penalized. Those who are doing questionable things are getting a raise. So it doesn't make any sense. So we need to fix this. And again, both parties need to come together and fix this. And I will say the Health Oversight Committee hearing, both parties came together, and Representative Comer said nobody's ever brought both parties together like the three executives of the PBMs. Everybody in that room was horrified at their actions. That's what we need more of.
Yeah, exactly. Any other questions from the audience? Take it back.
So first on that point, that it's not a question, but on bipartisanship, my boss and Buddy Carter were the ones who got their bill on banning spread pricing in Medicaid included in last year's CR, which of course, as you all know, has fallen out. So please.
And your boss is?
Sorry?
And your boss is? Who's your boss?
Representative Ross.
Yep.
North Carolina, District 2. So to the extent that you're interested, to keep urging people to keep that bill in mind and include it in something this session, we would appreciate that from y'all. But turning around to my question for you, for reimbursement times, by PBMs, broadly from my understanding, a lot of this is governed by state laws. And, we have heard concern from people in pharmacy about the implementation of the drug price negotiation program and potential delays in payments to pharmacies. And, from my understanding, the snag is that, waiting for that rebate to come from the drug manufacturer. In that meanwhile, pharmacists will have to essentially float that cash. It can also be, devastating for them to operate their businesses if there's no clarity or certainty there. First, on those, requirements to, reimburse within 14 days or 30 days for like Part B drugs, what, if any, improvements do you think can be made for the enforcement to make sure that those are actually happening in a timely fashion? And, on the in the way that this negotiation structure has been set up, does it provide a little bit too much leeway to the PBMs and put you guys, and particularly the pharmacists, on the, to foot the bill? Is there a better way to envision that moving forward? I know that's kind of a vague word.
So we have a flag for Rep. Ross's and Rep. Buddy Carter's bill to reform some aspects of PBMs, and then a question on the enforcement for sending the rebates to pharmacists and how that impacts their need to float money and the enforcement mechanism there and how we can better enforce it.
So first of all, the first comment that you made about spread pricing. So one thing that's really important to understand for spread pricing, for anyone that doesn't understand that. So the way spread pricing works is if we adjudicate a claim at the pharmacy and the PBM comes back and says, you're going to be paid $10 for this drug. Okay. Then what happens is that PBM goes to that plan sponsor, whether it's an employer or whether it's Medicaid, and in a spread pricing setup, that plan sponsor is then charged $50, $100, $500, when really all that was paid to the pharmacy was that $10. So that's where spread pricing happens. And I would say spread pricing is one of the highest cost drivers in these programs. If the plan is being charged a certain amount of money, it should not be exponentially higher than what's actually being provided or paid to that provider. So this is one